Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started.
Welcome, everyone, to Chicago. In the world that makes KidsX possible, I find there's still something to be said for the insights and community found in gathering in person. So we wanted to find a way to bring everyone together.
So far on this show, I've talked one-on-one with optimistic individuals who are working hard to improve healthcare for children. But behind the scenes, at hospitals, in clinics, at insurance companies, in venture capital firms, in state and federal government, are really important, motivated, hardworking people who work tirelessly to enable innovation in pediatric healthcare. Once a year, this community of innovation enablers gets together in person for the annual meeting of the KidsX Consortium. So on November 17th, 2025, 40 individuals from all over the world, from Seattle to Boston to Israel, got together in Chicago for a day full of networking, best practice sharing, and open dialogue about what's working and what's not working, and the challenges, and the optimism that lie ahead in 2026 and beyond. This meeting was for invited guests only. We recorded the entire meeting, and in today's episode, I will share with you the highlights so that you can get a better appreciation of the behind-the-scenes champions who are doing the hard work of making healthcare better for children and families. The KidsX meeting was sponsored by AVIA, a company that drives digital transformation across health systems. First up, AVIA's CEO Clay Holderman welcomed the group to Chicago and shared his appreciation for innovators in pediatrics.
I myself took my family through a journey with a child with osteosarcoma and spent 2.5 years going back and forth on a 7-hour drive, I-25 from Albuquerque to Denver, and trying to coordinate care between Children's Hospital Colorado and Presbyterian in New Mexico, and trying to get records to speak and information to cross and clinical trial eligibility to be possible. I understand this special mission that children's hospital leaders have. And I think very differently than adult hospital leaders. We deal with traumas, we deal with tragedies, we deal with exciting breakthroughs, but we don't treat the whole family in the same way that children's hospitals do. And we don't deal with a lot of the emotional support and the intense communication needs and the intense family decision support that's needed in this world. And yet, our children's hospitals and children's health systems are under more pressure, a disproportionate amount of pressure, than really the rest of the healthcare industry. And so, whether it is just the high disproportionate share of Medicaid that comes with women's and children's services, or it's the high cost of the experimental drugs that are used and the low end in many of the conditions we treat, or whether it's the access issues and getting people in and out of long distances, like I experienced with my family and coordinating care and all of the extra administrative burden that creates, or now thanks to OB3A and HR1, it's the disenrollment in Medicaid that disproportionately impacts this population. We understand that our pediatric healthcare institutions really do have a tougher road right now. And innovation is actually underrepresented in these populations.
Next, we had a discussion about patient experience. Stacy, the director of digital health and innovation at Children's Nebraska, spoke about her work to bring an innovative app to patients and families, helping them navigate the experience of being in a children's hospital using technology from a company called Gozio Health.
I am a pediatric nurse. I've been at Children's for a little over 27 years, and I've worked in various areas, med surg, emergency department, pediatric ICU. We have a brand new innovation center at Children's Nebraska that was opened last year in August. And our teams are working on our VR and AR programs, how we're promoting 3D, all the things we're doing, not only from a medical education perspective, but also from a patient engagement. It was probably 2021. We really took a hard focus and had a strategic plan to really expand and make a digital front door footprint. So we have a hospital proper where we have a parking garage, and that leads you to the main hospital lobby and some of our inpatient floors, those areas. But then we have a connecting building, which is our specialty pediatric center, which has 4 floors of ortho, GI, all of those different groups, and a separate parking facility. And when you've got a family who's coming invited here from 2 hours away, they've got 2 kids in tow, and they parked in the wrong parking garage. Now they've got to schlep all the way across our campus to get to where they need to go, hoping they know what floor they're going to, and hope that they get there on time. So as we started looking at some of those challenges that we could see, but we were also getting feedback on our patient engagement surveys, our patient satisfaction surveys, that people found it confusing. They didn't know where to go. They didn't know how to get there. And so this was really that jumping off point of where we knew we needed to make a change and make it easier for our families to get into our building, get into the floors quicker, safer, and make it convenient for them.
Stacy then showed us a demo of the app that she and the folks at Gozio built together, and she shared impressive data about how popular it was and the plans that she has for expanding its use in the future. Our next speaker was Ali Nasser. He is the manager of Insights and Advisory at AVIA. He gave us an insightful presentation about the current state of AI in pediatrics.
So 22% of the US population is under 18, and 1 in 5 AI solutions today repurpose adult models without pediatric validation. The other 80% don't even try. So you are looking at 20% of the top vendors, the top AI systems, who aren't even really trying to understand the PEDS world and PEDS data sets. Children are growing up in an AI-powered health system that is built for adults. I think PEDS has a really big advantage over adult systems where if you do it correctly, you see the patient from 0 to 18, and that involves so much. It is the toddler years, it is the elementary years, it is early childhood. This is something I came up with, implementation mythbusters. The first one is it is not technology, it is business misalignment. The myth here is if we build the right tech, we'll be able to scale it across all systems. That isn't true. The right tech is already out there. If you want to see where healthcare is going, just look at banking and retail and tech. That's where we'll be in 10 years. I was talking with the PEDS leader and I mentioned that. And then they said, hey, if you want to see where we're going, look at adult systems in 5 years. That's where we'll be in 5 years because we are very risk averse and we need to see something validated and go through all the troubles. Then we might think about incorporating it in a small rural hospital. And then we'll look at our big systems. I've got a couple more of these. It's not data, it is data, rights, and sharing. We've talked a lot about how we have all the data in the world, or it's already out there. Pediatric data is too scarce for meaningful AI usage. The evidence against that is parents control the consent. Parents see their kids every single day. They go to school, and the school health data, it lives in a legal gray zone. It is outside of HIPAA, but it's inside of purpose.
Then I invited 2 longtime friends and colleagues to the stage. First, Stephen Konya. He's the Chief Innovation and Strategic Partnerships for the Assistant Secretary for Technology Policy at the U.S. Department of Health and Human Services. He's shaped the agency's long-term innovation strategy, and he serves as the primary liaison to the White House and its Office of Science and Technology Policy. He manages the agency's relationship with external healthcare startups and the investor community. If you're a startup working in healthcare, you likely already know Stephen, and if you don't, you should. You have this core belief that government can help drive innovation, and that may be not a common belief amongst a lot of people. I think a lot of people may believe that government can sometimes get in the way of innovation or put barriers up, but you always not only believe, but kind of put your action behind this concept that government can be a connector, an enabler, obviously a funder, but also a driver of innovation. A catalyzer. So we're all here. These are pediatric experts. These are people who want to drive innovation to pediatrics. How do you think government, either state, local, or federal, could be an enabler of innovation, perhaps in a way that people here haven't thought about?
There's a lot of different ways. I think it depends on the government, the type of agency, type of individual. I would flip it a little bit on its head and say that each of you have a responsibility, I would suggest. Hopefully you're not offended by that. But I think have a responsibility to think through who are those government leaders that you need to engage to help you advance your agenda, right? And how can you not roll out the red carpet, but at least provide a space, have a seat at the table reserved for that. Doesn't have to be at the head of the table. Sometimes it will be. Sometimes it can be at the back of the table. Sometimes it's in the corner. Sometimes it's just outside the room. But always be knowledgeable about what government agencies, state, local municipality, federal, you need to be collaborating with in order to help advance your work. And I guarantee you, there's probably countless ways that you can identify opportunities for that. I'm happy to speak to any one of you about the ways that the federal government can do that and what agencies on the federal side. So, on a one-on-one call, they'll attest to this. I'll be happy to just workshop ideas of like where there could be agency that you can collaborate, learn from, leverage. And it's not just for funding, it's for policy coordination. I think that's probably one of the least activated spaces. We were talking a little bit about policy advocacy work earlier on Medicaid stuff. But that's one area where all of you are empowered individually as a person, but also, in the work that you're doing to be someone who's informing government about where there's friction, where there's opportunity in the marketplace, where they need government to lean in more, where they need it to be less restrictive, right? We put out everything for public comment. We want feedback.
We generally work with our elected officials, either ones that are federally elected or elected locally. But is there another kind of group of people or an office within state government that you think, in a group of innovators to build relationships with or invite at the table, like you said?
Yeah, absolutely. Every state's different. So I'll give you an example of that. In Colorado, Prime Health Innovation is one of those regional innovation ecosystem chain type organizations. And again, they're all different depending on the state, right? Sometimes it's a not-for-profit, sometimes it's a health system, sometimes it's a Chamber of Commerce, and National Healthcare Council is a subsidiary of the Chamber of Commerce. So it's always different depending on who's like leading the charge in that region, who's that safe space that brings everybody together. But in Colorado, they've got a couple organizations, and one of the ones that's been the constant over the years has been this group called Prime Health. And I've worked with several of their leaders who have cycled in and out. Sarah Lamp is their current head of their organization. But it's a not-for-profit. It's more of a virtual network organizing thing, but they do a ton of policy advocacy work on behalf of their community as well. And they partner closely with the governor's office of e-health innovation. And they actually have like working with entrepreneurship and hospital innovation centers and all of it. They actually have that like written into the state's e-health innovation strategy. There are a couple agencies within a state, sometimes in some of the larger cities, and then definitely at a federal level. Commerce, economic development agencies are going to relate to all that innovation related work. So access to capital, programs to help support entrepreneurs that you might want to work with, sometimes some pilot implementation grants that might be available. There's the rural health funding that I'm sure all of you are aware of. Most areas in the state apply for that. Then I know there's a few states that creatively went out, started organizing on that to get input from their communities and drafting and submitting those proposals. Some even set aside their own funding to put out grants to support rural health systems with adopting technology and so on, even ahead of when the federal funding was coming. So those economic development agencies are always valuable, and then obviously those on the healthcare policy payment side, it's going to impact all your revenue lines. You have to figure that out, and that's again, it's both at the federal and the state level. You have federal Medicaid and Medicare, but then at the state level, they can go above and beyond and do other things that they want with some of that, right?
So my last topic will be the current administration has indicated an interest in data interoperability, in wearables, remote patient management. These are all topics that I think are really relevant to people in this room from a pediatric standpoint. Is there so much of healthcare innovation still is adult driven and adult oriented? So you don't typically see a lot of children's hospitals at the table for these type of conversations. If there is a children's hospital that would be interested in either thinking about interoperability with federal or with wearables and some of that conversation, how can they engage? What's the best way for them to engage in some of the priorities coming out of the White House or the federal governor?
Yeah, again, it's hard to track. Certainly there's a lot happening. It's coming out very fast and in various. So you hit on some of the big areas, right? So there's a strong interest. For one thing, just raise your hand and say, we're interested in collaborating on this. One of the ways you can do that, CMS does have a page that you can subscribe or get engaged on their interoperability pledge. which is one of the ways that they're leveraging the loud bullhorn and purse strings of CMS to get more attention about supporting greater interoperability. And so there's a lot of organizations who have joined that, from health systems, the big tech companies, and all kinds of organizations. So that's one way to get more directly involved. And a lot of details still shaping up on the different things that you can get out of being part of that. But that's one simple way. We're going to be releasing more and more RFIs. I can't speak on which topics, but I'll just stay there relevant to what you've been talking about today. Okay. I'm expecting the coming months now that we're back open finally. I think we were hoping to release some before the end of the calendar year that may get pushed into the early part of the year, but I'll keep an eye out for some of those RFIs related to, again, some of those topics that we were talking about. And just for example, I don't know if any of these are actually going to be ones, but something related to AI or something related to your so, but definitely for those, and then coming on those, it's the simplest thing you do, costing nothing but time. You'll learn a lot through the process. It's a way of signaling of where government is thinking and wanting to go. Usually after that, you see policies that follow, rulemaking, et cetera. So it's going to impact the way that you can or cannot do your work that you're trying to do. And sometimes it's followed by funding opportunities or pilot opportunities as well. I know that there are things like that are being discussed for early next year, new funding and new pilot opportunities to become available. It's going to be informed by some of those RFI processes. So it's like, hey, we're thinking about this. What are your thoughts on that? What's a good way that we can do this? Then that is then turned into an RFP or request for proposals or a NOFA, there's a funding announcement. So yeah, you can help shape all of that by getting involved the earliest as possible, right? And again, if you have to enlist the support of some of your other staff, like those on Legend Affairs and others, who can help you write responses or whatever it may be, or suggest to KidsX and Kaja, sorry if I'm creating a short for you guys, but to say like, hey, these are our thoughts on this. Can you, do something, or we can also submit this in, because it is so relevant to what we're doing. Another thing is, hopefully all of you have seen, in the first Trump administration, the Childhood Cancer Data Initiative, or CCDI, was launched. How many here are familiar with that? So that was, kind of shelved or on pause for a little while, which was a lot of other initiatives being launched in the last administration relative to the cancer moonshot. But they just announced this summer, I think it was, another doubling it. So it was 50 million before, now it's 100 million for that initiative. And specifically, they want to invite AI tools being designed for the pediatric, childhood cancer community to be able to be trained and developed on this, shared data resource that they're building out. I think all of you have obviously data at your disposal, and you can think through how you might be able to contribute that, be part of the broader research community on this area, and then to think through what kind of AI tools are you working on, do you have partnerships with, or that you would like to see, and then help connect those to the initiative so that you can actually start to be customary. It doesn't have to be something that you personally are developing in-house at, Children's Hospital of LA or Nebraska or wherever else. But if you're working with an AI tool out there, seeing a lot of value on this, but I want it to be tested across a larger set of data. I want it to be trained to see how it works, in all these other settings, to help with some of the trust and accountability that was being talked about before. That maybe suggest that or encourage them to apply to be part of the initiative and figure out how they can leverage that resource for research. So
we'll talk about this in a minute with our next guest, but if I make a plug around wearables, the other kind of the topic we talked about, the pediatric population increasingly is wearing something on their wrist or has the capability and the desire to engage in wearables. But in terms of clinical grade wearables, we're still behind the adult space. And so as we think about those care models, how we can enhance development of these wearables, and we'll talk about it with our next speaker as well. But I think it's another opportunity for this group to engage with the federal government, especially since wearables seem to be, at least on the adult side, an area of interest amongst HHS.
Yeah, I would say next. I think it's even part of the MAHA report, where it specifically also calls out focusing on pediatrics and youth in general, supporting widespread adoption of wearables. I think the comment was they want to see a wearable on every single arm in America, and it includes children and adolescents.
It's a great opportunity for us to introduce our next podcast guest. But while we do, everybody, thank you. And then I invited my friend and colleague, Dr. Juan Espinoza, to the stage. To folks in pediatric device innovation, Juan needs no introduction. He's been a pioneer and champion for pediatric innovation ever since I don't know, ever since he got his first stethoscope. He's also the definition of a person with T shaped skills. He speaks multiple languages, plays multiple instruments, and at one point he co founded a digital media production company that worked with TV, film, and mobile technology in Hollywood. Very interesting guy who cares deeply about pediatrics and innovation. He and I worked together for many years at CHLA, and he's now in Chicago playing an important role at Lurie Children's. So, Dr. Juan Espinoza, in the world of digital innovation, in the world of medical device innovation for pediatrics, one of the absolute champions and pioneers in this space, also the chief research informatics officer at Lurie Children's Hospital. So, Juan, a great example of how the federal government has helped advance pediatric innovation are pediatric device consortia, which have a rich history. Do you want to talk about a little bit of the history?
So, for those of you who are not familiar, in 2007, Congress passed legislation, the PMDSIA. I don't know what all the letters stand for, but the P is pediatrics. And that bill included a number of provisions related to how do we make pediatric medical devices safer and more accessible to children. And one of the things it contained was the creation of the Pediatric Device Consortia Program, or the PDCs, which the FDA first enacted in 2009. And the PDC model is essentially a center of excellence, right? So how do we identify organizations who have the clinical, regulatory, and engineering expertise to help support and encourage early stage pediatric device innovation? And the program is now in its fifth funding cycle. In 2009, the most recent one was 2023. The program that Ali CTEP at Consortium for Technology Innovation in Pediatrics started at CHLA in 2013 under Giddy Barcohen, who's a wonderful cardiologist, electrophysiologist at CHLA. He's still there. He's still involved in the CTEP. He's like co-director. I had the incredible opportunity to take over the program in 2018 and have since we were able to grow it from in 2013 when it was first funded was just in Southern California. It was USC, CHLA, Cedars-Sinai, a couple of hospitals in the LA area are together. In 2018, we grew it to the entire West Coast. So we had 8 hospitals from Seattle Children's to Rady Children's and everyone in between. And then in 2023, we expanded now to 25 organizations across 8 states, with our new headquarters being here in Chicago, Lurie Children's.
So, congratulations on all that, Stacy. Expansion clearly indicates there's interest. How are you measuring success of your PDC, but also how is the government measuring the success of PDCs in general?
Yeah. Pediatric devices are tough to measure because you have to think about, are you measuring milestones? Are you measuring products to market? In different devices, for your higher risk devices or class 3 implantable surgical devices, high risk devices, those technologies might have a 7, 10, 15-year journey to market, especially if they're pediatric, and especially you're funding them from one grant to the next and not necessarily with venture capital. Originally, when the program first started, that's what they were measuring. Great, how many devices did you get to work? And the answer in the first 2 cycles was 0. We got 0 pediatric devices to market. These grants are 3 years. Their initial ones were 10 years long, 3 years long. This takes 5 to 10 years. The answer is 0. Of course, it's 0. And so by 2018, the FDA started shifting to more milestone based. So how many different groups were you engaging with? How many different projects you were engaging with? How often were you connecting them to existing resources, whether they were at the federal level, at the FDA, at CMS? Or how often were you establishing new clinical partnerships, new industry partnerships, new research partnerships? And then how far along the total product life cycle, which is sort of this framework that the FDA uses to measure how medical devices move from sort of concept to commercialization, how much can you move them down that spectrum? And that's become more realistic, and it also gives us more meaningful goals to work towards. That said, through for this, at least for CTIP, from 2018 to 2023, we had 26 new devices hit the market.
Wow.
Out of about 250 companies that interacted with.
Thanks. Congratulations. So talk a little bit about the ecosystem approach that you take at CTIP now and how it's evolved over time.
Yeah, I think one of the things that's most important about the ecosystem piece is that no one of us can do it. A, we don't have the right skill set. B, we don't have the right resources. C, none of us have enough money. If I took the entire allocation of 5 PDCs for 5 years, that'd be about $35 million. It takes a class 2 device, depending on the technology, of about $50 to $100 million to get. So we could take the entire federal budget and PDC program and give it to one company and still wouldn't get it. Right? It has to be strategic. It has to be partnerships. It has to be identifying what are the right catalytic steps that can help de-risk something or move it to the next stage so that someone else with more resources or who's at a different stage is interested in engaging. So a lot of it is building those partnerships through the ecosystem of trust, right? Those organizations who have the resources, who might gatekeep them a little bit because they have potentially more to lose, or they want to be very strategic in their funding, then what our role is, how do we get this technology to the stage where, it's now interesting per your check? And that requires not just our dollars, and all of us finding the right clinician. I may not have an expert in IBD at Lurie Children's, but I can go to UChicago and find one, or I can talk to my colleagues at CHLA if there's experts in epilepsy surgery. So I think building those networks, like no one organization has everything. And so we have to work together as an ecosystem to really advance this technology.
Question for both of you, ecosystem-wise investment, right? So pediatric investment, whether it's digital, whether it's med device, it's different for a potential investor to consider value in pediatrics or even a digital technology in pediatrics. How do we think we're going to be able to change that? How do we create more activity, more interest from investors who particularly for earlier stage devices or digital solutions? How can we get them at the table when a lot of their attention is on the adults?
Yeah, so we've taken a couple of approaches. One is bringing a different profile of investors, right? So folks who are more willing to invest sort of on more social impact lines, or folks who are willing to take a potential lower ROI. They don't expect a 5 to 10x. They might be happy with a 1.5 to 3. The other is thinking of pediatrics as a beachhead. Right? I'd like to think that the way we take care of children's, that's how we all deserve to be taken care of. Like this comprehensive family-based approach where we think about you, your environment, your education, your work, your family.
So switching gears a little bit, I want to get away from medical devices into innovation and kind of traditional innovation. So when I first met Juan, I first started working with Juan in 2018. First meeting I had with him as part of our innovation group, our medical director, he really wanted to get telehealth off the ground at Children's Hospital Los Angeles. Across the country, telehealth, it's there, it's steady, but it's definitely not where it was in the pandemic. Do you think we're at a place where it's going to continue to be at that 8 to 12% range, where it's going to take care of a certain number of patients? Or is there another innovation cycle that we're missing, at least in pediatrics, around new use cases of telehealth? Where do you think it's going to go?
I think that there's an opportunity to grow it. I think obviously the explosion during the pandemic was out of necessity. Yeah. And I think the attrition that we've seen for that is there are two components. One is the wish for and the final return to normalcy, although I don't have to do this. So the other is, I think that a lot of our workflows and user experiences are still terrible for telehealth. And faced with the alternative, oh, it's fine, I can just go see my doctor in person or see my healthcare provider in person. I think a lot of people do that. So I think the opportunity to recoup some of that is not necessarily better technologies, but better experiences, better workflows. And then I think also resolving some of the billing challenges around it. I think for a lot of families, the idea of having a check-in for remote patient monitoring or data review and saying, having that experience of, I had to pay my copay for you to look at my data and call me about my data. I think there's a disconnect there. So thinking about how do we deal with the billing component, the financial component of telehealth in a way that makes families feel like they're getting value and that it makes sense. I think those two things, to me, technology will be nice, but I think it's making it feel better.
Yeah.
That's really critical.
Okay, so let's move to the next one. Virtual reality. So probably even before the telehealth curve, VR kind of hit the scene, and you can talk about AR, but mixed reality and like that whole gamut. Where do you think that goes next?
I'm actually bullish. I don't know if it's a 2 to 3 years, more of a 5 to 10 years, but I do definitely see it ticking up, and for a couple of reasons of things that will happen in the next 2 to 3 years. Look at the intersection between this current administration's commitments to wearables, and then on the other side, your question on telehealth. Sitting right in between those, there's a lot of work on digital therapeutics. And some of the most successful digital therapeutics to date so far have been in the behavioral health space for pediatrics and adolescents. So that's an area that I expect is going to be a technology that's further adopted and supported and reimbursed and so on. And that'll help support even more virtual ways to deliver care and services, including just full on telehealth. So it's like further extending out into the community. And in general, there's bigger commitments around that. If you look at some of the largest healthcare systems, integrated healthcare system for the whole country, most of them have a pretty robust hospital at home program that they're still supporting and growing. And telehealth is a big piece of extending that as part of that hospital at home program for virtual connections and doing ongoing visits in between.
So one of the things I think enabled that in the adult space was the federal government. I think bundled payments and then Medicare Advantage and other plans that incentivize new payment models, which then force hospitals to think about new care models. We haven't seen as much of that in the pediatric space. Partly it's because pediatrics is largely administered, reimbursed through state-based programs. But I think there's something around whether it's federal or state incentives in terms of payment models that could further fuel innovation in care models.
Yeah, I think that piece is critical. You had asked me sort of, if I would change one thing about how the federal government largely relates to innovation, and it would be the fact that there are 56 Medicaid directors in this country, right? And if you have figured out one, you have figured out one.
Yeah.
And that's a problem for families.
And then when you figure them out, they leave their and I got to figure that out.
Right. The comment there is basically every state has one and the territories have one. So that's why that's based to 56.
And they change all the time.
They change all the time.
So it's a problem for families, because depending on what state you're getting care in, it's a problem for companies who are trying to innovate in this space because you figured out one payment structure and now you have to figure out the next one. So you can't scale nationally. If I would change one thing, it would be, I'm going to cheat. I'm going to combine them. I think it's having a national coverage decisions for pediatrics in the same way that CMS does it for adults. Now, whether that's because we carve children out of Medicaid and add them to Medicare or some other structure, that
was a lunchtime conversation I had earlier.
That's my vision.
Talk about that a little bit more.
Yeah. So CMS for Medicare has created a lot of innovative payment models, has created bundled payments, has created value-based payments, and Medicaid simply hasn't. And there's a lot of reasons for that. But a lot of the innovation in care model is driven by the opportunity to be compensated to deliver innovative care models. So if you had an infrastructure where you could say, okay, great, Medicare today is 65 plus. Well, we said, what if Medicare was 0 to 18 and then 65 plus? And you could then have both, at both ends of the lifespan, centralized national policy on what gets paid for, what gets reimbursed, and the opportunity to leverage these innovative care models. I think it would be huge for pediatrics and for pediatric innovation.
What makes you optimistic about the future?
I think that there's so much cool stuff left to do. Fundamentally, despite the regulatory issues, the funding issues, there's almost nothing else I think I'm doing that makes me feel so fulfilled, like I did something good for the world. And we have more and better tools every day to solve those problems. And sometimes we are creating those tools. And that keeps me going.
Agree. There's so much to do. And I feel like we could be back here in 5 years and talk about all the great stuff that we've accomplished. And it'd still be more there. Yeah.
Let's see, there's a couple of things. One is just the speed of technology advancement. And it's becoming AI in itself and all the subsets of AI. We were talking a little bit about this earlier in the sense of digital twins. I think there's so much opportunity, especially in the ped space where the risk is so high of doing something directly invasive and testing it in clinical trials, where else it may be, where you can run simulations through digital twinning technology in advance to help come up with a very tailored, specific for that patient type of intervention and model it and run it through, simulate it and so on without actually having to, be invasive in that patient. But there's just all of that gives me hope in general, but specifically in the ped space, I think it just comes back to what you're talking about before, the fact that it is one of those safer places to collaborate. So I tend to think that it's an area where you can see earlier adoption of certain things because of that.
On the flight over here, I was putting together a presentation about AI pediatrics, and there are two things that stood out to me. One, every one of the studies that I found were multi-center studies. So it was different children's hospitals working together, partly out of necessity because they need the data, big data, and pulling together data from different geographic sources helps. The other was that the groups that were coming up with it were all around the world. Nigeria, Sweden, India. The barrier to study data and research and build these AI models the barrier is so much lower than it was perhaps a decade ago or 2 decades ago. So it gives me optimism that A, we're working together, and B, to your point about the pace of innovation, the barriers to innovation, they are lower. The barriers to generating and developing this stuff. I mean, there's college students, even high school students someday, that can build and run these AI models that can change the world. Thank you to our guests. And before we wrap, that I thank our sponsor for today's podcast and our sponsor for Hugh Ralph. I want to make sure we thank them for being a sponsor of today's podcast. QRATS is a new technology that's taking the waiting out of rounds that we all round in our organizations. And this is a unique technology that enables that. So I'm going to share a little story that I think illustrates what QRATS can do. So when Ryan and Anne McQuillan's twins were born over 4 months early at 22 weeks, they entered the NICU at Fairview Assigned Children's Hospital in Minneapolis during one of the most fragile moments of their lives. Little did they know that in the midst of constant fear and clinical uncertainty, a first-of-its-kind application had just gone live in their NICU, and it would provide a literal lifeline. The neonatology team had just started using Q rounds, a virtual rounding queue that sends real-time updates to nurses, patients, and families with when to expect the doctors for rounds. And it gives families the opportunities to RSVP to join rounds remotely when they can't be there in person. So each morning, Ryan and Anna would receive a simple text from Q rounds that include their position in the rounding queue and an estimated time for round. Sounds just like a waiting list at a restaurant. This small act of time transparency enabled them to be present in person or virtually every single day during their nearly 6-month hospital stay. It wasn't just about showing up, it was about showing up informed, included, and empowered. They collaborated with the care team, shared insights about their babies, personalities, and advocated for treatment decisions during daily rounds. As you think about preparing for those rounds, you don't miss the thing that you have people write post-it notes, all these things to remind them. It's interesting. So more than 30,000 families have joined Q rounds remotely in that one NICU, and the nurse to family present for the entirety of rounds has more than tripled. Q rounds is now live in multiple hospital settings and is automating the inclusion of nurses, families, interpreters, which is important because so many pediatric families don't speak English or English as a second language. And more for the most important part of the hospital day by taking the waiting out of rounds. If you're part of a pediatric hospital or an innovation team, visit qrounds.com to see how Q rounds is making multidisciplinary family-centered rounds an achievable standard of care. Q rounds, taking the waiting out of rounds. So there you have it, a sample of highlights from the 2025 KidsX annual meeting. I hope it gave you some background on the thoughts and perspectives from the unsung heroes, the folks behind the scenes who partner with the innovators and help bring innovation to the forefront of care delivery in pediatrics. A big thank you to our sponsors, AVIA, Gozio, and Q Rounds for their support of this meeting. All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and thank your crossing guard. And if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast. CHLA does not endorse the views, opinions, and information presented on this podcast, and CHLA specifically disclaims any legal liability or responsibility for the podcast content.